Welcome to the session on ABO, Basic to Advanced Concepts. Our objectives are going to be to cover the ABO blood group antigen system and the automatic antibodies of Landsteiner's law. We'll be speaking to ABO genetics and outputs, the nomenclature of the different antigens, the existence of isoagglutinins and the types thereof, when they dawn and why, the selection pressures behind ABO evolution and the current global distribution of ABO types, and the relationship of ABO to matters such as coagulation, platelet transfusion care, complications in IVIG therapy, and finally, significance as a histocompatibility barrier in both solid organ and bone marrow transplantation. There are two tubes that the blood bank foundationally works with, though the vast majority of the time we prefer to use specimens submitted in EDTA because both the red stuff and yellow stuff are examinable. This is a permanently anticoagulated material where the red cells can be pipetted up and examined. The plasma has not coagulated out. It's called plasma as long as the coagulation cascade has not completed itself. That's in contrast with the red top tube, additive-free, glass contact activation, and so forth with no calcium chelation means that the complement and coag cascades go to fruition. And what you have then is a clot specimen, some solid matter at the bottom, red cells and fibrinogen and so forth, with a clarified yellow stuff at the top, so to speak, called serum. Serum, of course, the basis of serology and the historic practice of using these specimen types for clarifying work on the nature of antibodies, free-floating, lying in wait, not yet bound to their target, and therefore examinable on different interrogation surfaces. So as you can see, the EDTA specimen is quite ideal for us to work with in the blood bank. When we talk about indirect phases of testing, we're describing the interrogation of plasma antibodies or serum antibodies, again, not yet bound to their target, but waiting for us to determine what they land upon if we have informative laboratory investigative surfaces. Direct testing in the blood bank essentially constitutes a biopsy of the red cell biomass, just as direct immunohistochemical work on a kidney specimen after a transplant to query rejection is another example of direct testing. Direct testing examines the actual tissue of potential injury. And in the blood bank, direct testing, of course, is looking for the deposition of complement or antibody on the red cell surface. When it comes to ABO, there are two sides of the coin, and we are exploiting both the red stuff and the yellow stuff in our testing. We have two universal reagents by which to determine whether or not the patient expresses the A or B antigen or both or neither. And that's the blue-tinged anti-A reagent and the yellow-hued anti-B reagent. So ABO forward typing is an example of direct testing, as is RHD typing and any other minor red cell antigen phenotyping work. Again, if we are interrogating whether or not the red cell surface is under immune attack with IgG or complement, that is also the penultimate example, the most familiar example of direct testing from learners to experts alike. And so that is the direct Coombs test, the DCT, or the DAT. Now, if we pipette up the yellow stuff, that's indirect testing. Our interrogation surface that reveals what it is that an antibody might be binding to are the reagent red cells whose antigen profiles are known to us. And so we can deduce patterns of reactivity and therefore specificity. In the world of ABO, when we work with the plasma, we are running the plasma in 2 test tubes against A1 red cells as the reagent red cell of interest, or group B red cells. Reactions in that phase, known as backtyping or reverse typing, reveal to us what isoagglutinins a person has. And these should be reciprocal to their forward type. In other words, obey Landsteiner's law. When we pipette up yellow stuff and run the screen, that is an indirect Coombs test for the minor red cell alloantibodies. Again, we're using the antihuman globulin as our detection molecule. If a person is screen positive, their antibodies must be deemed compatible with respect to the antigen negative selected unit. This is a proof of concept. This is a validation of safety of the proposed unit. It verifies that the candidate red cell has been well selected and is bypassing the antibodies that the patient's plasma is currently laden with. When we do indirect testing, we are using, or we are favoring typically, a monospecific anti-IgG, anti-human globulin. Though in the direct Coombs test, we often use a polyspecific reagent to find either complement or IgG as the deposit. In the blood bank, we work under 2 thermal conditions, either room temperature or cold conditions. Of course, we can get colder than that, but typically speaking, room temperature represents the easiest access cold phase. We don't need to do anything or take more heat out of the system. It's already 17 degrees cooler than in vivo or warm conditions. The 37-degree incubations aim to imitate what's going on in vivo to recapitulate the best binding conditions for IgG. Cold antibodies, or IgMs, are so called because they're really obvious by virtue of their capacity to pentamerize with each other. IgMs naturally form these quaternary structures. And if you have an IgM whose Fab binds to erythrocytes, well, these are going to get linked up and produce visible agglutinates. The more heat you take out of the system, the more organization you're going to have of this quaternary propensity. So IgMs, the mu heavy chain defining those, have agglutinative power. And because of this, these tend to stay intravascularly confined. They're notorious for their complement fixation, and they have a shorter half-life of 5 days. So some clinical pathologic archetypes are examples: the cold agglutinins, the IgMs that bind to red cells, typically autoantibodies, cold agglutinin disease or cold agglutinin syndrome. They're the ABO isohemagglutinins. You don't need any other reagents to see these binding to A or B structures. You can work at room temperature. And finally, other IgMs not applicable to ABO are those that might be the clonal signature of Waldenstrom's macroglobulinemia, the excess output of which produces hyperviscosity, or cryoglobulinemic vasculitis. IgMs, again, because they are intravascularly confined, are much more amenable to apheresis. Now, this is in contrast with IgGs, which are monomeric. And the goal in the development of a seroconversion response to an antigen of importance is ultimately to isotype switch from IgM to IgG. The monomeric nature of this IgG gives it a much vaster volume of distribution. And of course, that makes sense if this is provoked into being in order to fight an infection. You get better penetration. These can go transplacental. These can also be complement binding, and these have a much longer half-life. So some archetypes for pathologic IgGs include those of warm as opposed to cold autoimmune hemolytic anemia. Carl Landstein was actually trying to figure out stomach acids, but at the age of 31, he next made the move of mixing the sera of his colleagues with the red cells of other members in the lab, and he found that some didn't agree with each other. So there were agglutinates formed in some cases, but not all. And the basis of this differential agglutination, the revelation of different types, blood types in humans, came to be known as the ABO system, still the most commanding of all blood group antigen systems today because of the existence of naturally occurring isoagglutinins. The core structure of the ABO system is the H antigen. Before the addition of fucose, the precursor to H is I. The H antigen itself can get glycosylated with the immunodominant sugar that defines the blood type. The A immunodominant sugar is GalNAc or N-acetylgalactosamine, and the B defining sugar is galactose. The Bombay blood type is the failure to fucosylate the I antigen. So instead of having red cells having the H base structure, there is only I. And these individuals make naturally occurring antibodies against the fucose that is present on H. As such, the transfusion of group O or H positive red cells is an act of incompatibility with respect to the I only expression Bombay individual. This is a very rare blood type, and these individuals can only be transfused with Bombay blood. Here we have the 6 genotypes that give rise to the 4 phenotypes with the expected plasma antibody. The ABO system is codominant, so that an AO essentially has equivalent A expression, at least on the red cells, as AA individuals. And likewise, the same applies to the group B concepts shown here. The genes behind glycosyl transferase activity are shown here. The hominid wild type, the original version of this glycosyl transferase gene, was group A, or GalNAc favoring. The first genetic alteration in the ABO system was the occurrence of the group B glycosyl transferase, which is reflected by 2 SNP changes, which lead to altered amino acids in the catalytic domain of exon 7, favoring the work with galactose instead of N-acetylgalactosamine. The group O mutation is a deletion, which leads to a premature stop codon, which leads to a prematurely truncated polypeptide that never makes it to catalytic domain exon 7. The current distribution of ABO types, generally speaking, is shown here. Given the codominance of the ABO system, this therefore deduces that 67% of the ABO genes on Earth are actually group O. And that's quite a feat given that we began as group A hominids. So clearly there is something that has promoted the ascendancy of the O allele, despite the fact that you need homozygosity in order to witness that particular outcome. So despite its hidden nature, O nevertheless ascended. O is now the most common blood type on Earth, and these individuals are also carrying the widest and most intense variety of isoagglutinins. So not just anti-A and anti-B in the IgM form. IgM's typically the first pass or first raised antibodies against carbohydrates, but also the IgG version. And an antibody with a compound specificity known as anti-A, B. The existence of these A, B type antibodies was established in adsorption and elution studies. That is to say, you could take the plasma of a group O individual and run it against an A adsorptive surface, and then elute that material and prove that the A selected antibodies have cross reactivity with B substance. You can repeat that maneuver vice versa. You would not have that outcome if you had in your plasma only a blend of anti-A and anti-B as separate antibodies, because the adsorption of anti-A on its elution examination would only therefore react with A antigen. So the O donor plasma antibody repertoire is quite rich and is exactly what puts them at highest risk of a more severe hemolytic reaction if the O individual confronts A or B antigens in a human error event, such as an ABO mistransfusion. Theoretically speaking, a group A or a group B person getting mismatched blood is less likely to hemolyze as severely because they tend to have their reciprocal isoagglutinin in IgM form. That would be the dominant isotype, and maybe the only one at all if you were to run immediate spin and indirect antiglobulin test phase titer assessments, that is, room temperature reflecting the amount of IgM, and IAT 37-degree tests reflecting the amount of IgG. You can see that group AB is the rarest of the ABO types at only 4%. And these individuals, by virtue of expressing A and B, would have no reason to develop antithetical anti-A or anti-B. And so this is an ideal plasma if needing to transfuse someone with an unknown blood type, because it won't present hemolytic isoagglutinins to a recipient with unknown blood type. So how or why do these isoagglutinins arise? Well, some studies in the 1940s on leghorn chickens examined what happened to chicks that were hatched into perfect sterility versus those exposed to the prokaryotes of natural life. Chicks hatched into total sterility did not develop their equivalent of isoagglutinins, which in chickens would be an anti-B. The default state, however, developed this as the immature creature's immune response was developing. So not one that you're born with, but one that dawns within weeks to months of life. Probiotics and prebiotics can increase the titer and present the A or B substances that incite the development of this innate antibody repertoire, as it were. So an individual's titer of anti-A and anti-B can theoretically increase in accordance with their dietary intake. And we see this as sometimes a feature of relevance in the investigation of donors who are implicated in hemolytic transfusion reactions from minor or plasma mismatched platelets given to individuals. They may have been a repeat donor and not exerted any harms in the past, now after a change in their nutrition provoke more hemolysis as their titers have increased. So there is a somewhat complex quagmire to unpack when we look at the vascular biology of tentative ABO interactions in various clinical scenarios. ABO antigens are expressed on cells. One can also secrete the free A or B antigens that define their blood type. And so this is present in both the plasma as well as in secretions in a soluble form. An individual has their Landsteiner's law obeying isoagglutinins, again, those provoked by the commensal microbiome of the aerodigestive tract. Now, there are two versions of A which speak to the A antigen in both qualitative and quantitative terms. Let's take, for example, the Group O person who needs a kidney transplant. Ideally, they would get a Group O graft, but if one isn't available, there is the option of crossing the ABO barrier. If you are looking at a Group A potential donor, the kidney may or may not be ideal. And what defines that difference is whether or not that donor is A1 or non-A1. Individuals who have the A1 glycosyltransferase, the wild type, the high efficiency version, express many antigens on the red cell and have the capacity to glycosylate the N and O-link glycans that are present on the endothelium of the kidney. And so the A1 donor is less ideal because the renal allograft will present histoincompatible A antigens to a Group O host. The weaker subgroup of A individual, the person who is not A1, doesn't really do this. The reagent that distinguishes A1 from non-A1, such as A2, is the dolichos biflorus agglutinin. You can see here that there are 6 different kinds of sugars upon which the ABO system can be expressed. Type 1 and type 2 are the most commonly expressed antigen types, and they are the ones of high relevance on our red cells, as well as in our plasma and our secretions with adsorbable antigens. So a bonus layer, so to speak, for red cells and platelets. A1 glycosyltransferases are capable of decorating type 1, 2, 3, 4, and 6 base sugars with GalNAc. However, if you are A1 negative, the so-called A2 or non-A1 glycosyltransferase only has the power to apply GalNAc in type 1 and type 2 sugars. As you can see here, kidneys only express type 4 glycolipids, and those are not subject to GalNAc glycosyltransferase activity in non-A1 individuals. And this is the explanation for why these donors can be acceptable and virtually ideal. Now let's go over the structural difference of A1 versus A2. The A1 glycosyltransferase is handy at repetitively applying GalNAc to available bonds. And so you can get more complex and branched oligomeric expressions of this sugar. The A2 glycosyltransferase is not as efficient and tends to just have a GalNAc end group on a short chain that, by analogy, is like little I versus big I. So A1 has this power to generate long and multidimensional arrays of GalNAc. And what this does is create a quaternary structure of GalNAc cloud-like complexity that, in the eyes of an A2 or non-A1 individual, can, in essence, look like a foreign structure. So this is how and why a non-A1 person can be found to have anti-A1 type antibodies. The dolichos biflorus antigen, as you can see here, can distinguish A1 from A2. Now, in the concept of geno-phenocorrelation, there are always more genotypes than there are phenotypes. The majority of mutations, and this should not be surprising because mutations usually produce a degradation in the original quality. The majority of mutations produce weaker subgroups of whatever glycosyltransferase gene might be involved. And so you could see that the majority of A genotypes, in terms of variant diversity, are ones that diminish the intensity of expression rather than conserve it. Over here on the left is a list of a number of weaker subgroups of A. So you can see that A2 is just one of numerous kinds. So if you are not A1, it doesn't automatically mean that you are A2, although A2 is the majority non-A1 type. When you're looking at a discrepant blood type, it is important to describe what you're seeing in a systematic way. It helps to do troubleshooting, problem solving, and to generate your differential diagnosis. And so in the world of ABO, we talk about forward and reverse types. And if you are seeing a discrepant type, it is good to describe whether or not your forward typing discrepancy, if it exists, is due to an additional or a reduced degree of reactivity. Conversely, if you have a reverse typing discrepancy with respect to a forward type, you want to describe that as an additional reactivity versus a reduced reactivity. So to give some examples, a forward typing discrepancy might be a weaker A phenotype coupled with a reverse typing discrepancy, which may be an additional reactivity on the A1 cell. So that might be the giveaway of a weak subgroup of A with counter A1 sensitization. An individual might have a perfectly straightforward AB forward type, but their reverse typing discrepancy may be additional reactivities that are unexpected against the A1 and B cells. The group AB person should not have those reactions, but if they exist, it may be a clue, for example, to the presence of nonspecific cold agglutinins acting at the room temperature immediate spin phase, testing conditions of reverse typing. Conversely, a group O person may have a reduction or lack of reactivity expected in the A1 and B cell test tube. So rather than seeing the 4+ reaction with A1 and B cells, these reactions might be weaker or may have disappeared entirely. And so we may see this in Bruton's agammaglobulinemia, common variable immunodeficiency, B cell ablation states. We can see this after CAR T therapy and after very aggressive plasma cell reduction therapies. So myelomas are the treatments thereof. When you look at discrepant blood types, you can also posit causes such as medical error in terms of transfusion scenarios. There may be an apheresis scenario. There may be a dynamic change due to chimerism. So an ABO mismatched bone marrow transplant, for example. So you can imagine a number of explanations for a variety of forward and reverse typing discrepancies. There is also the phenomenon that is important to know of acquired B, something that only group A people are at risk of. The A antigen is transformed into something that structurally is rather B-like under the influence of a clostridial infection with exotoxins that may include deacetylases. The N-acetyl group of galactosamine may be clipped off to reveal galactosamine, which, for all intents and purposes, may look enough like the galactose B-defining antigen to be subject to the hemolytic effects of a group A person's own naturally occurring anti-B. So this is horror autotoxicus, or the ability to hemolyze by an unintended serologic suicide. When GalNAc turns into galactosamine, this is, in essence, a cryptantigen state. Now, ABO evolutionary dynamism, what's the story there? The ABO system began its mutations, and specifically the O mutation, roughly 5 million years ago. And it's been an ascendancy ever since, with the dominance of O and the increasing diversity of weakened subgroups of A. So, in essence, an apparent attempt in evolution to escape one's anus. It raises the question of whether or not it's the absence of the A or B sugar that is good. In other words, is A or B a vulnerability tag for bugs? Or is the permissive sensitization to the A and B structures by their loss, i.e., the development of that innate humoral repertoire of isoagglutinins that might be good? Can this naturally occurring isoagglutinin repertoire defend a host against certain pathogens by being a neutralization substance? If we take the insightful goggles of JBS Haldane, who noted that there was a virtually exact overlap in the malaria endemicity map with the sickle allele frequency. If A is the original blood type and O is the ascendant variant state, what is intriguing to see is that O outnumbers A in all of the malaria endemic countries illustrated in this table. And that's in contrast with parts of the world that the African exodus was hence populated by, that was not subject to that ongoing degree of malaria selection stress. And so A's, the wild type, continues to dominate in those less pressured, more northern climes of planet Earth. So does your reverse type neutralize malaria parasites? Is this the explanation? No. If it was, this would be a susceptibility factor, and there appears to be no difference in the odds of people of different blood types contracting or actually getting the malaria infection. So this is an equal opportunity pathogen. What is different is once you have the infection, how it interacts with you as a host. And so a parasite-induced change of host erythrocytes may be interacting with uninfected red cells and other tissues that express ABO antigens in their own way. And indeed, this is what is seen in the clinical epidemiology of malaria infection. ABO appears to be a severity factor, and there appears to be a very cogent biologic model to explain this. In the middle panel here, you can see malaria-infected red cells, which have these parasite-encoded purple knobs, PFEM, or Plasmodium falciparum erythrocyte membrane protein 1. These are promiscuous cytoadhesive structures that exploit host vulnerability ligands, such as the A or B antigen in the ABO system. And as this figure shows, A's or B's are expressed on red cells, on the endothelium, on platelets, and even on von Willebrand factor. And so each of these can represent interaction points with a malaria-infected red cell. Malaria-infected red cell can handily rosette with uninfected red cells and thereby create this shroud of immune invisibility so that the infected red cell does not get recognized by even any innate pattern recognition motifs that may be present on monocytes and macrophages. By tethering itself down onto the endothelium, malaria-infected red cells can also avoid flow into the spleen, which, as we appreciate, is the body's giant red cell editor. So this is advantageous to the parasite, which can thereby avoid clearance within the spleen and thereby broaden the speed of its infection. This unfortunately also produces harms because cytoadhesion, be it infected red cells on the endothelium or in rosettes with uninfected red cells, can essentially mechanically jam the microcirculation and cause obstructive ischemias, giving rise to WHO defining severe malaria archetypes such as systemic lactic acidosis and coma states or cerebral malaria. Shifting left, the contrast then is the group O person, where PFAMP has nothing to bind to. This is now an unstuck erythrocyte that will more readily flow into the spleen and have the range of infection thereby limited in this innate way. The spleen is able to act before any adaptive immune system response kicks in. It is essentially an innate filter. Now, can you luck out if you are group A or B or AB? Well, there are mitigants to the cellular vulnerability of your ABO expression, and that is the extent to which you freely secrete the free A or B antigen. The soluble A or B antigen can interpose or interfere with that PFEMP binding upon cellular surfaces and essentially unstick these cells like a talc, giving liberation and hence increased clearance potential. So mitigating or interacting blood group genetics include the secretor positive Lewis A neg B negative blood types. These can significantly increase the concentration of soluble A and B substance in one's plasma and potentially mitigate the effects of malaria-associated cytoadhesion. In systematic reviews and meta-analyses, you could see that the O and A risks in terms of the severity of malaria are mirror images of each other. The extent to which O lowers risk is the extent to which having A increases it. Is this sufficiently explanatory? Does this convince us of causality? Well, the Bradford-Hill criteria are very helpful to scientists and natural philosophers to figure out if what we're observing as an explanatory model and in terms of the meta-analytic epidemiology suffice to build a case that malaria is the driver of ABO diversity. So is there an effect size? Is there reproducibility, specificity, temporality, biologic gradient, plausibility, coherence, experimental proof, and analogy? Virtually all of these are actually upheld in the ABO malaria relationship. What did we find? Well, many of the Bradford-Hill criteria being upheld. There was an ABO severity gradient effect if we looked at uncomplicated malaria, safe enough to be managed as an outpatient versus inpatient management. and the severe malaria spectrum, which ran from admitted severe WHO criteria defining survivors and those who died of their infection. So you can see that there is A enrichment, the more severe the syndrome classification gets. When we looked at severe malarial anemia versus the non-hemolytic archetypes, so lactic acidosis or cerebral malaria in black, the more severe versions of severe malaria syndromes were enriched for the A1 type. You had more A1 positive individuals in non-SMA presentations versus the severe syndromes present in those negative for A1. In this logistic regression, A or B was statistically quite significant as a predictor of a severe or fatal outcome, more so than this statistically non-significant protection from having sickle trait, though this was not as common in the Ugandan population that was examined. In terms of real-time selection, those who were healthy enough to serve as adult donors in the Uganda National Blood Transfusion Service were even more enriched for O, and less A-typed than the children who enrolled in the study. And in fact, the ABO distribution of children who entered the study with their new malaria infection and those who exited the study as survivors was itself shifted within a single pass of the study. So this is evolution at work in real time. Finally, odds ratios. The A or AB type in death versus an uncomplicated course was 50% versus 30%. Or said another way, the odds ratio for death versus uncomplicated malaria for A or AB versus O was 2.3-fold. Now, ABO is also expressed on platelets, and here, zygosity actually matters. We and others showed flow cytometrically that the AO genotype has a less dense expression of A on platelets than homozygotes or AB heterozygotes. Because platelets are involved in the vascular biology of malaria infection, it's possible that this is a genetic tipping point by which AOs increase in the population to eventually permit the jackpot OO offspring to develop as AOs interbreed. Otherwise, it's very hard to explain the ascendancy or an almost psychic insight on the homozygous benefit of the O type. Now, ABO has a relationship to yellow stuff, that is, to platelets and to plasma. One's von Willebrand factor, as mentioned, is ABO glycosylated in accordance with one's blood type, and the non-O von Willebrand factors, A, B, and AB, are a little more resistant to ADAMTS13 mediated von Willebrand factor cleaving metalloprotease activity. In this trauma paper, all-cause mortality was much increased in Group O people, and this may have had to do with more than just bleeding alone. But the idea here is that Group O people, because Group O von Willebrand factor is more easily cleaved, naturally run lower VWF levels. And in fact, if you give VWF levels according to ABO types, the Group O VWF distribution overlaps with the upper end of what defines type 1 von Willebrand disease. So no question, Group O's have less VWF and non-O's have more of it and a more proteolytically durable kind. This therefore means that Non-Os have a well-established propensity to clot more than Os, and particularly in the arterial sense, where VWF and platelet engagement are so important in high flow states. This blood paper showed the greater speed or ease with which non-O platelets tack down as opposed to more prolonged rolling in group O individuals before platelet adhesion is finally achieved. So, what are the implications of all of this? Well, the vascular biology of the non-O individual is fraught with a higher odds of thrombosis, and in malaria, more cytoadhesion. If you have a malaria-infected individual, even though there is no definitive RCT to prove the superiority of group O over type-specific blood, there is the temptation to imitate evolution, so to speak, to enable the escape of cytoadhesion. So if confronted with a red cell transfusion opportunity or necessity, to give group O red cells if you have sufficient inventory to do so, as opposed to the type-specific blood, which would potentiate that person's cytoadhesion once their hematocrit is restored allogeneically. And if you have to transfuse yellow stuff, if you have an opportunity or a reason for a plasma transfusion, such as the treatment of an associated coagulopathy, there is the temptation to give A or AB plasma for the sake of introducing soluble A antigens, which can act as, again, an interposing or interference agent with respect to PFEMP binding with cell host ligands otherwise. The traditional approach, of course, and the standard of care approach is to poison with a parasiticide the parasite itself. Use your antimalarials, your artemisinin and derivatives, and so forth. The problem is that these drugs are expensive, and malaria is always evolving faster than the speed with which pharma companies can develop, a next generation agent that is effective against all strains. So resistance is a problem. And no matter how much drug access you have, how soon you use it, you cannot change the burden of PFEMP expression already present on cells. And so if you want to bypass the membrane molecular lesion that is already present, then maybe you want to block the Trojan infected RBC with the merits of conscientious or conscious chemotherapy. So again, using group O red cells or using soluble A antigen-based plasma products to imitate evolution and to serve in a manner that is complementary to drug action. Let's change gears now to some ABO transfusion multiple choices. What is the universal red cell type? Group O red cells. They lack A or B structures and can get transfused down the line to A's, B's, and ABs. The reverse, however, does not apply. What is the universal plasma type? It is AB plasma lacking anti-A or anti-B, and therefore not inducing hemolysis, and likewise AB recipients or A or B or O recipients. Trick question, what is the universal platelet type? Well, because platelets are dual entities, they're both a cellular product and a plasmatic product from the suspension fluid, the conventional suspension fluid up until 2023, 2024 is the plasma of one of the constituent male donors. If you have such a dual product, even if they are from the same ABO type, you have no such thing as a universal platelet. The only exception is an ABO identical platelet donor, which is by definition not universal. So an A to an A, an AB to an AB, these are the ideal choices. And the only thing that gets a little less fraught is if you have a platelet donor or a platelet source that is known to be lower in its expression of A or B substance. For example, the O heterozygous A's and B's, suspended in a fluid with no or minimal anti-A or anti-B. And so that could be in the plasma of a group AB person or in a platelet additive solution that is free of isoagglutinins. In other words, this choice contrives a universal platelet option. Now, practically speaking, you have to pick an ABO. We relegate group O's, or we invite group O's to be whole blood donors for the sake of their useful red cell mass. We invite group AB people to be plasmapheresis donors. When it comes to platelet apheresis, or an AB type that is favored for stock enrichment beyond the ratios shown in the aforementioned ABO pie graph, A is essentially our best choice. The A donor is appealing because this is the second most common blood type after O, so they're quite abundant, and you don't have to steal from your O whole blood donors in this regard, because most A's are AOs rather than AA homozygotes, and you can do the polynomial math to convince yourself of this. The AOs are going to have less A expression, so many A's actually don't have a lot of A expression upon them. And the plasma of a group A donor lacks anti-A, which therefore means these individuals have plasma that is inoffensive to 85% of recipients. The plasma of a group A person will not harm an O and will not harm likewise group A people. O's plus A's, 40 plus 45% gives you 85% of recipients free of this harm. As we think more about ABO relationships, it's good to characterize, if you're talking about a donor and recipient interaction, what exactly is interacting with what. So be systematic in your imagination or in your approach. When it comes to a major compatibility question, we are talking about whether or not the cells in a product or an organ bear membrane surface intrinsic structures, A's or B's, that can be subject to harm by the antibodies in a host patient's plasma. A major incompatible mistransfusion would be an A into an O, and likewise, a group A heart into an O recipient constitute the offenses of a major mismatch. The flip side of minor compatibility is asking about whether or not the plasma or the concentrated antibodies in a given product, such as IVIG, bear hemolytic anti-A or anti-B that could be relevant to the recipient receiving that infusion or that graft that might be secreting from its passenger plasma cells a passenger lymphocyte secretion effect that could hemolyze a host's erythrocyte biomass. This is the cartoon for an acute hemolytic transfusion reaction, donor erythrocytes being infused in to meet host alloantibodies. The recipient can destroy the unit in its entirety by virtue of the infinite or ongoing production potential of the antibody that can destroy the incompatible antigen. The mistake of ABO mistransfusions, and this is a so-called never event, happens in a number of ways. The literature describes IBCTs, or incorrect blood component transfused events, as occurring 1 in 14,000 times. Of course, the ABO is the most dreaded example of that. If there is an ABO major mismatched red cell transfusion. Why or how does this happen? Foundationally, it's because the patient identity was not verified at the bedside. This is either at the moment of specimen collection, so-called WIBITs or wrong blood in tube events. These occur in 1 in 2,000 specimens, and this is why we have bedside practitioners swearing on their professional license that they collected from the correct patient after positive patient identification by signing the label with their initials and the date of the specimen draw. So this is how important PPID is at the blood transfusion specimen acquisition point, because if we are submitting a wrong blood in tube, we could be doing all the right things in the lab and preparing group A blood for what looks like a group A person who is actually group O. The sticker might have been transposed at the bedside. Someone else got collected from to represent the group O patient. A group A person is representing a group O person to their great peril. The other scenario is errors in blood administration. So a group A and a group O person are in beds next to each other. Both are getting blood delivered at the same time. Both have similar last names. It might be two people in the same room, a kidney donor to a kidney recipient. If the bloods for two people with the same last name cross over from hanging in haste without careful patient identification, a blood administration error can produce an ABO mistransfusion. In the lab, we are sometimes the agents of mistake. So a laboratory clerical error, writing the wrong blood type into the lab information system despite all the right readouts on the bench, or a technical error, the reagent not having been added in, or something going on with the readout. So there are other ways to mistype an individual, but this is an illustration of really the sharpest point of risk, which is the bedside practitioner in the longest bar of the graph. The mirror image now of the acute hemolytic transfusion reaction in the passive sense is when the yellow stuff type product bears a hemolytic antibody, and so that can be the plasma in a platelet or a bottle of IVIG. So this animation here showed passive acute hemolytic transfusion reaction, minor incompatibility. Now, IVIG can cause hemolysis. About a third of people getting high-dose IVIG, if they are not blood group O, so A's, B's, and ABs, can have a positive DAT or exhibit sensitization, and a third of that third can have a clinically significant grade 4 hemolysis. An important predictor of this phenomenon is not having the benefit of co-treatment with other immune suppressants. So IVIG by itself at high dose and non-O recipients can be quite harmful, and we need to be conscious of this in our informed consent. Another example of an intravenous immune modulator that can cause hemolysis is IV anti-D when we deliberately give it to an RHD positive individual as an alternative to IVIG treatment for immunomodulation in the treatment of ITP, for example. And in this case, there is a black box warning on the monograph for this product, which is given in much smaller quantities compared to IVIG, but which illustrates a similar principle. And so we should not be comforted by the fact that there isn't a black box warning in IVIG. Not to say that there should be, but that we should have a high awareness and, in fairness to the patient, a transparency about this particular risk that is personalized. So it is wise to have your patient's ABO type on file, and if it's not known, to draw this before the IVIG administration so that we have a base sample in it, so we know what risk to predict or inform the patient of. This cartoon here is showing in an egocentric way the mnemonic convention for major incompatibility. Major incompatibility is about the host having the immune firepower against an incoming alien donor material. So this is all about rejecting a product. the O person who rejects the A mismatched red cell transfusion and culminates in fulminant hemolysis, the A stem cell graft in the O recipient, the A platelet into the O recipient having increment failure. Minor incompatibility, I put in quotation marks, isn't always minor because the graft can sometimes do pretty wicked harm. Minor incompatibility is when the immune factor is externally derived and coming in to the innocent host. It is not the host's fault that this is happening. The minor mismatch is a graft blame. So this is a graft that is rejecting a host. All minor incompatibilities, therefore, by definition, are examples of graft versus host encounters. An O plasma being given to an A recipient can cause hemolysis of that group A host. An O stem cell graft can elaborate passenger lymphocyte anti-A secretion activity that can hemolyze residual host A red cells, and an O platelet suspended in O plasma bearing anti-A can cause recipient hemolysis, just as in the example of IVIG-mediated hemolysis. Now, at UHN, we have our own nomenclature. We have a notation for hybrid blood types in our lab information system to help enable the identification of appropriate products. This takes the cognitive work out of figuring out what to give to whom and helps to prevent medical error from ABO mistransfusions in Chimera. Our convention is to use a 3-digit name for a blood type that begins with X if it's a solid organ transplant recipient of an ABO major mismatched graft, or the prefix letter T if it's a hematopoietic stem cell transplant. The first digit position after the X or the T is the ABO type that is native to the host, the blood type that the recipient, was born with. And the next digit or slot is for the acquired or graft-defining ABO type. And so the examples here, XOA is a person born group O with an A donor. That's a major incompatible solid organ transplant. An XAB is a bidirectionally mismatched born A donor B transplant scenario. The TOA is the BMT patient who was born O and transplanted to A. The TAO is the opposite, born A, donor group O. And the TAB is the bidirectionally mismatched BMT. You can have major incompatibility 5 different ways. The antigens of A or B or both are what are alien to the recipient who is pre-armed with the isoagglutinin. And so an ABO major mismatched transplant is subject to graft loss. And in the world of BMT, as long as the isoagglutinins are secreted, and they shouldn't last for more than 3 to 4 months after the BMT, unless it was a minimally ablative or low dose BMT. Isoagglutinins, once they clear out, will enable unfettered engraftment or non-attack of the A or B expressing graft cells output. Pure red cell aplasia will therefore occur more often in non-myeloablative regimens over myeloablative regimens. The erythrocytes that are being erythropoiesed out of the graft in the new marrow niche are not surviving very long if there are persisting isoagglutinins. Because red cells express more ABO than other tissues, pure red cell aplasia is therefore the lineage dominant syndrome of partial engraftment failure. So this is a delayed red cell engraftment or an apparent non-erythroid engraftment due to ongoing isoagglutinin conflict. The reverse in minor incompatibility also goes 5 ways. So if the recipient is AB or AB, a donor who is lacking that antigen, but who has the isoagglutinins against the host's antigen, can land on that antigen in the acute phase if there is a non-isoagglutinin depleted graft, a plasma-rich graft, or a high titer graft. And even with depletion, if there is a sufficient load of plasma cells, those plasma cells, once they've engrafted in the recipient as passengers with the stem cell infusion, can, within several weeks, secrete a high enough titer to be hemolytic to the host's residual A or B expressing cells, namely the red cells. So DAT positive passenger lymphocyte syndromes can occur within a week or two after the stem cell infusion, but typically begin to subside after that point. All possible players are present in the worst case scenario bidirectional mismatched BMT. So incompatibility runs both ways. The A antigen in a recipient can be subject to the anti-A isoagglutinin of a group B donor, and the anti-B of the group A host can attack the group B structures of the group B donor as they attempt to engraft. So this subgroup of ABO mismatch can be seen in some big data BMT cohorts as having inferior outcomes to other ABO pairings. The most daring transplants are listed here. So major mismatches. An A, a B, or an AB to an O are major mismatches, and so too are ABs to A's or B's. Minor mismatches, again, are about the plasma isoagglutinins that a graft can spew against a recipient's cell surface A or B antigens. Bidirectional mismatches, 2 examples, A into B or B into A, and the ideal of no conflict, ABO identical in the last row. The probability of any kind of ABO incompatibility in a stem cell transplant is obviously highest in matched unrelated donors, which therefore may be a confounder in those outcomes compared to matched sibling-related donors. The odds of an ABO suitable donor, ABO identical, is much higher in sibling-related or haploidentical donors. So this probability table helps to explain the expectation of ABO mismatch in the MUD scenario. Our grafts come in 2 preparation formats, bone marrow or apheresis-derived peripheral blood stem cells. You could see that each of these have different amounts of contaminating plasma and contaminating red cells. Bone marrow, the heaviest for both, therefore meriting some kind of graft processing activity to mitigate acute risks of either of these sources of ABO relevant trouble, be it the isoagglutinins in plasma, if it's a minor mismatched scenario, or the erythrocyte biomass that may be enough to cause an acute and very serious or even fatal hemolytic transfusion reaction if infusing a major mismatched graft. This table here shows some of your cleanup options for major, minor, or bidirectionally mismatched transplants. You can manipulate the graft or manipulate the intended recipient, depending on the different scenarios of whether or not the graft or host titers are high. So for example, if you have a major mismatch transplant, an O recipient, for example, who has a high anti-donor titer, anti-A, well, you can manipulate the graft to ensure that it is red cell depleted, or you can apheresis the patient to skim off their host isoagglutinins. Conversely, in a minor transplant, a minor mismatched transplant, the concern is the titer of the isoagglutinins in the graft. So if you have a high plasma volume containing graft, you'll want to plasma volume reduce that. Alternatively, you can prepare this recipient of a minor mismatched transplant by scooping out, for example, their group A red cells and getting them transformed into an O type in advance so that any passenger lymphocyte activity doesn't cause hemolysis of the residual group A red cells in this individual. The bidirectional mismatched transplant tempts you with the most graft manipulation, which again, the more you manipulate the graft, the more you might reduce the residual CD34 count and increase the cost of that graft's management. And so a bidirectional mismatched transplant may call for red cell depletion and plasma volume reduction, a double maneuver, top and bottom, so to speak, which may mean a less enriched graft at the end by the time of the infusion. So another theoretical reason or example for why this might be a setup for a worse outcome. So what are the archetypes again? For major and minor mismatched transplants, TOA or Joan is the individual who develops delayed red cell engraftment or pure red cell aplasia from a red cell adoption failure. There might be acute hemolysis of the contaminating red cells of an improperly processed graft that's a little too bloody, and there may be delayed establishment of active red cell production from that graft. So graft reticulocytopenia and pallid anemia, and ongoing red cell transfusion dependence. And that's in contrast with the minor incompatible archetype of TAO, for example, or Naomi. This individual may have a delayed, potentially severe hemolytic anemia. The historical recipient red cells may be getting hemolyzed by donor antibodies, either those present in the plasma of the graft or in the delayed hemolysis by passenger lymphocyte isoagglutinin secretion. And so this is a more jaundiced hemolytic anemia as opposed to a pallid hyporeticulocytic anemia in major mismatched BMT. So the truth tables, you can never go wrong in red cells if you choose group O erythrocytes. They will overcome any of these mismatches. But if you have an AB into an A, you can give the shared A antigen A type blood, and likewise B for an AB into a B or a B into an AB. Okay, so these truth tables here should make sense for what your first and what your conversion choices are. We do not convert to the donor's blood type until the host isoagglutinins have disappeared and the DAT is negative. In the meantime, you won't do wrong to give the first choice for as long as necessary. Platelet concentrates, again, because this is a dual product, are a bit trickier. The first choice is a platelet whose plasma is going to be non-hemolytic to your donor-recipient pair. As you could see, there are no O's as your first choice. So we want isoagglutinin minimized plasmas in these platelets. We would not convert the platelet concentrate ABO product of choice to the donor's type until there is no more expression of the host residual erythrocytes. And by this, we would not want to give group O platelets to the minor mismatched BMT until the A or B or AB host's own red cells have dissipated. Otherwise, the residual host's red cells may be subject to hemolysis, just as any other group O to a non-O recipient's red cells may be imperiled. The second choice, what can always be done, is plasma volume reduction of the inferior or less available choice of platelets if they possess an isoagglutinin of relevance to your donor-recipient pair. For frozen plasma, the common thread running through here is AB plasma, universal plasma, just as universal O red cells are the common thread in the red cell choice. Again, we would not switch over to the donor's plasma type for plasma transfusion until the host erythrocytes have disappeared. There are these theoretical proposals for how to support major, minor, or bidirectionally mismatched transplants depending on what phase a person is in. So, in the conditioning period before the stem cell infusion, we stick with the recipient's group, but then begin to switch over to the ideal red cell type after the stem cell infusion. Again, this is showing how long we give the group O red cell or AB plasma for, and when we finally make the switch. This is all dependent on whether or not your host has cleared the isoagglutinins that may be harming the graft, and whether or not a graft's passenger lymphocyte activity or a product's isoagglutinins might be continuing to harm the residual host matter. Does ABO mismatching have a clinical impact? Well, across the studies, overall, the answer is uncertain. There are as many papers that say yes as say no, and this can be for outcomes from time to neutrophil engraftment, time to platelet engraftment, acute or chronic graft versus host disease, non-relapse mortality, disease-free survival, and overall survival. Here's an interesting case. This recipient is group A. Their stem cell donor is group O, and the recipient was screened positive for anti-E, and the donor happens to also be big E positive. What do you call this? Well, this is a major minor, minor major mismatched BMT. Essentially, this is a bidirectionally mismatched transplant. For the major system, ABO, there is a minor mismatch. This is a TAO. The group O is plasma incompatible with the A host, can secrete anti-A. So this is an example of a minor incompatibility in a major system, as well as a major incompatibility in a minor system. So all the antigens beyond ABO-RHD are your minor red cell antigens, the Cs, the Es, Kells, the Kids, the Duffys, the MNSs. If your donor has a major mismatch of a minor antigen to which the recipient is presensitized, that is technically still a major mismatch, though the system or antigen involved is quote unquote a minor antigen allele. So this is a major system minor mismatched and a minor system major mismatched. How do we make sense of what to give in such a scenario or in any other mismatches? We have to look in both directions before crossing the street. The best blood choices are those that do not bring an antigen in that can offend either the host or the donor's immune antibody repertoire. And it is to avoid bringing in any antibodies and plasma containing substances like platelets that could harm either the donor, the engraftment attempting cells, or the recipient's residual red cells. What is enzymatically converted to O? That is the holy grail of converting A's, B's, and ABs into O material, be it universally transfusible O erythrocytes or even graft modifications. It turns out that our own human microbiome has a species, Flavonifractor plautii, which secretes glycoside hydrolases that have the power in this deacetylase galactosaminidase combo to convert the A to O antigen. An ex vivo lung perfusion model using these Kzymes, so to speak, were able to digest off GalNAc from lung tissue to create a universally transplantable O-like lung graft. Were such a technology to scale up and be validated in an actual human implantation, this was an ex vivo model assessing for pre-post antigen load. If this scales up to success, this will obviously increase the availability of lung grafts, which are so tied to ABO as a histocompatibility constraint, O's only being able to get likewise O's. Now, ABO also has relevance in COVID. There was quite a striking signal on various GWAS studies, and these Manhattan plots showing a high frequency of relationship at the locus of the ABO polymorphism. Non-Os are likelier to get COVID, and non-Os are likelier to have severe infection. So this is even more complex or dualistic than the malaria story, where it's not about your ABO influencing whether you get the infection, but rather the severity. COVID is a both ways disadvantaged situation if you are not blood group O. And this is because your COVID viruses are also ABO glycosylated in accordance with the COVID infected person's blood type. A group A COVID infected person sneezing out aglycosylated COVID viruses is going to be better neutralized in the nasopharynx of a group O person who has anti-A. The anti-A will be able to neutralize some of the incoming ABO cloaked COVID virus. The non-O individual, because of their higher VWF levels, and because COVID is itself a thromboinflammatory state, is at much higher risk of severe outcomes in every vascular and thrombotic sense of the disease's pathogenesis. And so this is integrating what we've learned about ABO and coagulation. And so we will end there because we have covered ABO evolution from A to non-A via P. falciparum as the selection force. Our isohemagglutinins are provoked by our commensal microbiome in the aerodigestive tract. The A and B substances that we lack are the ones that we develop this isoagglutinin repertoire towards. There are many ways to have ABO typing discrepancies and mechanisms, and it's important to be able to deduce what some of those might be if you're faced with a discrepant blood type. Arterial coagulation has a strong relationship to ABO. O's just to dichotomize simplistically, would bleed more and non-Os would clot more. ABO, again, is a major histocompatibility barrier until we figure out how to create universally converted to O grafts. In the world of blood producers, A platelets dominate for a variety of technical reasons. That is, until we have ABO zygosity as a way to identify thrombocytes that are suitable for transfusion to all, and until we have platelet additive solution suspended platelets. IVIG can hemolyze because of its anti-A and anti-B contents. IVIG getting pooled from thousands of donors, and not all brands having the anti-A or anti-B adsorbed out in the manufacturing process. A's and ABs being most susceptible to hemolysis, and O's, of course, the least because they don't express the target. And many mysteries in ABO remain. So, though malaria appears to explain ABO evolution using Bradford Hill criteria and various kinds of basic science and global clinical epidemiology studies, but a number of diseases seem to have associations. And so the explanatory model for how or why that works remains to be elucidated in some cases. Thank you so much for listening.